Okay, I guess we can start. So you have plenty of time for questions. Great. Okay, hi everyone. Today we're very excited to have Dr. Tisha Wang speak with us today. She's an associate professor of clinical medicine in Division of Pulmonary and Critical Care Medicine. Dr. Wang got her MD with highest honors at UTMB at Galveston, followed by an internal medicine residency here at UCLA and a pulmonary and critical care fellowship. She's been the clinical division chief of UCLA Pulmonary Critical Care Allergy and Sleep Division since 2016. I think that's a very impressive division with so many different areas. And she received the Sherman M. Malinkoff Faculty Award this year, which is an annual award given to faculty whose teaching exemplifies the art of medicine and the finest in doctor-patient relationships. Dr. Wen is on multiple NIH and industry-based trials and studies in chronic obstructive pulmonary disease, asthma, smoking cessation, interstitial lung disease, ICU medicine, and COVID pneumonia. Clearly, her background is just, perfectly positioned her for COVID research. And she also conducts research on pulmonary complications of liver disease and a rare lung disease called PAP, pulmonary alveolar proteinosis, which is also a very interesting disease. And she's been the clinical director and vice president of the patient-based PAP Foundation and chair of the education committee for the American Thoracic Society. And we're very excited to hear your work today. Please take it away, Dr. Wang.
Thanks so much, Melody, for that really nice introduction. I wanted to start off with just a couple of disclosures. I am on the research steering committee for one of the clinical trials I'm going to be talking about. I just joined about a couple of months ago as we started to enroll a lot of patients. And I do sit on a pulmonary adjudication committee for GSK, actually on the medications that block GM-CSF. And so I just wanted to give those disclosures. My actually big disclaimer, despite that introduction, is that I primarily consider myself a clinician and an educator. And do sort of conduct some research, but I don't consider myself a scientist. So I'm not sure that I'm qualified to speak to a scientific group like this, but I will do the best that I can and certainly give a clinical perspective. So as all of you know by now, COVID critical illness is largely hypoxic respiratory failure. It's the most common manifestation. It culminates in acute respiratory distress syndrome, or what we call ARDS. But the patients can also get multi-organ failure quite commonly. Acute kidney injury, cardiovascular complications with elevated troponins, myocarditis, pericarditis, arrhythmias, sudden cardiac death, liver injury with transaminitis. The neurologic complications clinically have been very hard to manage. Actually, delirium and encephalopathy, probably part of this is related to the amount of sedation we have to give these patients, especially with how hard they are to ventilate once they become ventilator dependent. But secondary bacterial infections are actually relatively rare early in the course. There's maybe some difference later in the course. And then something that's very specific to COVID that's been talked about from day one is coagulation issues. So they both clot and they bleed. This sometimes can cause strokes, but often will cause venous thromboembolism like PEs or DVTs. So one thing I have been for the last 10 years is actually the training program director here. And so because of that, I have a number of trainees all across the US practicing pulmonary critical care medicine, some of them in the community, some of them in academia. And you can see the data on this x-ray of March 29th. One of my old trainees called me in desperation. This was actually a cruise ship worker that had docked in Northern California. And this is one of the first patients that this community hospital saw with COVID. And they basically asked whether or not I had a Hail Mary pass for this person that they really couldn't ventilate and couldn't put on ECMO. And so again, I think from the beginning, this causes a very, very severe form of ARDS with essentially no normal lung here. So multiple lab findings, as we have discovered, portend a very poor prognosis, certainly lymphopenia, but as well as lymphopenia, the elevated inflammatory markers, so CRP, ferritin, LDH, D-dimer, as well as elevated cardiac enzymes, specifically troponin, and then acute kidney injury and liver failure. This makes sense as we see multi-organ failure lead to poor prognosis in general in the ICU, but specifically these inflammatory markers and having a low lymphocyte count. This is something that was published very early in the Lancet to suggest the clinical course of this. I think I would actually change this graphic now to extend it way beyond, sort of 20 to 22 days, as these patients are surviving but staying much longer, and actually dying but staying much longer. But the point is that, from the very beginning, COVID was felt to be this cytokine storm. And we've known for years in the setting of sepsis and ARDS as ICU docs that it's not often the organism that kills you, it's the body's immune response that kills you. And so we've been for a long time looking for this, magic anti-inflammatory agent at exactly the right time that can quell this immune response. We can see here in this sort of picture that patients actually are going to be RNA positive even at sort of day -2, day -3. But these patients are basically 9 or 10 days into their course of symptoms before they even develop these complications, and that's quite common. There's a group that will, of course, survive and again be discharged. Some of these patients will stay longer than this. Some of these patients will get better quicker, but this is sort of the average that was sort of published at the very beginning of the pandemic. For the non-survivors, however, they're getting sepsis followed by ARDS, followed by all kinds of multi-organ failure that lead to death. And again, our experience at UCLA has been that some of these patients are actually, whether they're survivors or non-survivors, spending more than a month sometimes in the ICU. With that said, what really is cytokine storm? In a sense, sometimes it's a colloquial term we use in the ICU when someone comes in and they just look inflamed. They have fevers or tachycardic. You could imagine that if you measure their blood that they would have a hyperactive immune response with the release of a variety of inflammatory markers, including interferons, interleukins, TNF, chemokines, and other mediators. These mediators, of course, are part of the innate normal immune response needed to clear the infection. But at the same time, these cytokines themselves are also causing injury to host cells. And so when COVID first came about, just because of how bad the ARDS was, there was an assumption this had to be a cytokine storm, similar to what we see in other viral infections like flu, as well as sepsis in general. So very early, people have had medications potentially to block some of these inflammatory cytokines. And so multiple candidates very early in the pandemic were brought forward as like, I have a blocker for this inflammatory mediator. These are medications that are used in other conditions, specifically for IL-6 blockade. We use it in cytokine release syndrome for patients getting CAR T cell therapy, for cancer. Anakinra, the GM-CSF antagonists and antibodies are used in rheumatologic disease, as are TNF inhibitors. The JAK-STAT pathway was also looked at. And so multiple of these drugs basically were attempted to be repurposed for COVID. And frankly, they were being given very early in the pandemic with essentially no data that these patients felt very inflamed. And so we had TOCI in the hospital and we would give TOCI to these patients. Another thing that we always have toyed around with in ICU medicine and has gone pro and con, but in general does benefit a lot of patients with ARDS is corticosteroids. And this is, of course, a non-specific anti-inflammatory. We also use corticosteroids in sepsis in a little bit of a different way to treat relative adrenal insufficiency, but there has been a role for steroids in the ICU for a long time. Interestingly enough, when COVID first came out, the WHO came out and recommended against steroids, and many professional societies followed and recommended against steroids because of the experience with SARS. So many of us that we were kind of itching to give steroids at the beginning actually did not give steroids for the beginning of this pandemic. And actually, as most of you know, it's actually become standard of care since. But these are the medications that were sort of brought out, and many other medications too being repurposed for COVID. I'm going to spend a lot of time talking today about GM-CSF, which is a target that I have been interested in for a long time and have sort of been the PI for a couple of the trials here targeting GM-CSF. So it's important to note, though, that we really, again, didn't have a lot of data when this first came out. And so is COVID really a cytokine storm? And I think some of the arguments here are that perhaps it's not the cytokine storm that we thought it was. So if you look here, this is actually a summary of COVID-19 patients and their IL-6 levels in the entire population and in severe disease. And you can see some of them are high-ish, but they're actually not that high. So you can see 7 to 64 in severe disease, 7 to 45, depending on, again, the reference value for each of these labs. This is compared to sort of 3 really large clinical trials in ARDS that have been done in the last decade or two. Alveoli, FACT, and sales. You can see here that the IL-6 levels here were in the hundreds, and for the hyperinflammatory group, they were in the thousands. So again, are we calling COVID a cytokine storm without actually knowing what these mediators are in a given patient at a given time, which has always been the challenge actually of treating these patients, which can be very quite heterogeneous. This is another study actually looking at the cytokine levels in critically ill patients with COVID-19 compared to other conditions. So compared to sepsis with ARDS, compared to sepsis with no ARDS, for example. This is outside hospital cardiac arrest and trauma. You can see here that in general, COVID-19 with ARDS has sort of less or lower cytokine levels compared to sepsis with ARDS and sepsis with no ARDS. And this is in TNF. This is an IL-6 and this is an IL-8. And so again, though many of us thought this was a cytokine storm, perhaps it wasn't the cytokine storm that we thought that it was. So GM-CSF is again something that I was interested in my sort of pre-COVID life. I sort of divide my academic stuff in pre-COVID and post-COVID, but in my pre-COVID life, I did study GM-CSF in the context of a rare disease called pulmonary alveolar proteinosis, which is a complete lack of GM-CSF. And that syndrome leads to a surfactant accumulation. It also leads to a relatively mild but real immunosuppression to certain pathogens that require alveolar macrophages. And so what GM-CSF is it's a pro-inflammatory cytokine. It's produced by a number of immune cells, macrophages, T cells, fibroblasts, and endothelial cells. The most production occurs at sites of inflammation. And it is very much a critical homeostatic factor in the lung, as it is involved in the differentiation of alveolar macrophages, which obviously is essential to clear respiratory microbes. So there's been interest in this as a target even in regular ARDS many years ago, and sort of animal models as well as randomized controlled trials. And again, this sort of came about because I actually will sit on some of the adjudication committees for the GM-CSF blockade agents to see if patients get pulmonary alveolar proteinosis or other pulmonary syndromes, which interestingly they don't get, because probably you need complete blockade of the access, and these drugs are not completely blocking the pathway. And so through my collaborations actually in pulmonary alveolar proteinosis, I got called probably the first week of the pandemic to see if I was interested in participating in sort of GM-CSF pathway research when it came to COVID. So actually, myself and Eleanor Lee, who's also a faculty member here, helped publish this article about the rationale behind GM-CSF as a potential target. GM-CSF, again, binds via these alpha beta chain receptors. It's thought to be sort of activated by a viral infection, and then GM-CSF itself will activate other myeloid cells to produce inflammatory cytokines. It also primes T cells, which activate pro-inflammatory myeloid cells and recruits them to sites of inflammation. But what's been the most fascinating thing about GM-CSF is that there has been groups in COVID that want to give GM-CSF very early in the course, and there's been groups that want to block GM-CSF. And so there are a number of review articles out there about the rationale behind both of these. So the group that wants to give GM-CSF and sargramostim, which is basically leucine. So I use inhaled leucine on a regular basis for pulmonary alveolar proteinosis. Again, it's going to help these alveolar macrophages differentiate, potentially increase phagocytosis to fight off the virus. But the sort of inflammatory response that COVID causes potentially could be helped and blunted by GM-CSF antibodies, which are Gimsulimab and Linzilimab, are antibodies to GM-CSF, or Mavrililumab, which is actually a GM-CSF receptor. It blocks the alpha chain of the receptor here. So again, there's a camp that wants to do, that wants to give, and a camp that wants to block, which again seems somewhat counterintuitive, but that's sort of the rationale based on what GM-CSF does. So there's a published RCT in regular ARDS in 2013 when they gave GM-CSF, which failed to improve outcomes in acute lung injury. There was no toxicity, but it did not improve outcomes. If you look at animal models, GM-CSF does protect mice from lethal flu-induced lung injury and does protect against secondary bacterial infection in a post-flu pneumococcal pneumonia model. And so the company that actually owns Leucine, which is a medication again given subcutaneously for certain types of cancer, but also given inhaled for PAP, though admittedly off-label, is now in a phase 2 open label trial to use inhaled GM-CSF with primary endpoints of changing the AA gradient by day 6 and hopefully decreasing the amount of patients that are intubated by day 14. Now, inhaled GM-CSF, because I have a lot of experience with it, is actually a fairly well-tolerated drug without a lot of side effects. And so I think that giving it inhaled in this situation, the question is whether or not you're going to make the inflammatory cascade worse, but often that inflammatory cascade is mediated by inflammatory mediators in the blood. And so giving it inhaled may actually seem like a safer route than giving it subcutaneous. But there's a bigger camp of people, myself included, that have actually felt that GM-CSF is a potential target to block it late in the setting of hyperinflammation. So what we do know about GM-CSF is that it is elevated, at least compared to healthy controls, in the setting of COVID. These are two separate publications. One, this is still a preprint for full disclosure, but this is basically showing pathogenic T cells that have a very high expression of GM-CSF, and these are sort of density plots looking at the GM-CSF expression in these gated T cells. There was a separate study looking at blood levels, and so again, compared to healthy controls, we know that GM-CSF is high in both ICU patients and non-ICU patients. And so again, related to whether or not we think these things are even high to begin with before we try to go in and block them. So all 4 of these medications, actually Gimsulimab, Mavrililumab, and Linzilumab, and Otilimab, are being tested in separate RCTs. The nice thing about the GM-CSF blockade is that there is experience with this in other conditions, largely rheumatologic disease, especially RA. You do have acceptable safety profiles. And again, I mentioned that I do sit on some of these adjudication committees to make sure that none of these patients are getting pulmonary alveolar proteinosis. 3 of these medications, Gimsulimab, Lenzi, and Otilimab, are antibodies that bind to GM-CSF, and Mavri is a GM-CSF receptor antagonist. So at the very beginning, when the sponsor was looking for the target population, Steve Chang and I here weighed in that we want to aim these towards inflammatory patients that actually have poor prognostic markers as soon as they get on oxygen. So it's certainly late in that we're not giving it very, very early before they develop or before they come to the hospital. But obviously giving it not too late is the key. And I think timing is everything when it comes to using these anti-inflammatory agents. So we'll talk a little bit more about the inclusion criteria a bit later. So very early in the pandemic, these were the kind of things that were being published and very small sort of case control studies. And so these were the first 2 that were published using GM-CSF blockade. This is a case control study of 12 treated patients versus 27 matched untreated controls using Linzilumab, and showing improvement in 2 points on the 8-point ordinal clinical endpoint scale, which I'll show you very soon, because that's been what we've been using a lot for COVID outcomes. But there was 92% of the patients who got Linzilumab improved at least 2 points on this 8-point ordinal clinical scale, compared to 81%. And the time to clinical improvement was shorter for the treated group, which was statistically significant at 5 versus 11 days, as well as the proportion of patients with ARDS were significantly reduced. So again, with the caveat that these are really, really small studies, but this is honestly all the literature that was being published at the very beginning of COVID. It was like 10 patients here, 12 patients here, and oftentimes even sort of anecdotes and non-published data, and people were sort of acting based on that data as well. Mavri, and actually this was done in Italy, and so very early, Bruce Chatnell is actually one of my collaborators in the world of PAP, and very early there were conversations with a physician in Italy, in Milan, named Dr. Dagna. As you all know, Milan was hit very, very hard, and so in desperation, they were trying to find some therapeutic agent beyond what they had, and so Dr. Dagna, and actually, sorry, there seems to be, yeah, okay. There's something support coming on the screen. So Dr. Dagna actually got in touch with Conixa, and Conixa actually gave them some doses of Mavri, and he did this single center prospective cohort study where he took 13 non-ventilated patients with severe COVID with hyperinflammation and gave them 1 dose compared to 26 control patients. And again, in relatively small numbers, or really small numbers, had no deaths in the treated cohort versus 27% deaths in the controls, but again, had more rapid clinical improvement, and importantly had no notable toxicity. So this is actually a graphic from the same study where they looked at probability of clinical improvement in Mavri compared to the matched contemporaneous controls, as well as probability of fever resolution. So that's the published data we have in GM-CSF, which again I think is fairly minimal, but it did lead many organizations and pharma companies into wanting to study this. This is a clinical endpoint scale that has been really adopted by many, many trials, NIH and pharma for COVID. And so essentially a change in 2 or more on the scale is supposed to be clinically significant. 1, of course, is ambulatory with no limitation. 8 is death. So for example, if you're able to get someone from invasive mechanical ventilation with organ failure extubated on non-invasive ventilation or high flow oxygen, that's felt to be a clinical significant change. And or you get this patient on high flow oxygen to no oxygen. And so again, wanting to go down on the scale by at least 2 and using that as an endpoint for many clinical trials in the setting of COVID. So the first trial that I became a PI on was a Gimsulimab, which is called the BREATHE trial. This started very early in the pandemic, I believe in April. It was a phase 2, phase 3 RCT with the primary endpoint that they went pretty ambitious and actually went for mortality. We enrolled 27 patients total into this trial, and they were targeting hypoxic inflammatory COVID-19 patients who were decently hypoxic, on 4 liters of oxygen or more with a certain PF ratio, all the way to mechanical ventilation. And they could have multi-organ failure, but not severe multi-organ failure. So for example, they could have acute kidney injury, but they couldn't be on dialysis. They could have shock, but they couldn't be on high-dose vasopressors. Again, to target a patient population that hopefully had a chance of surviving. This is a 1-to-1 ratio of GEM versus placebo, with the dose given on day 1, and then a dose given on day 8 at a half dose for those who were still on oxygen. So this trial was actually stopped a bit early, 227 of 270, after the analysis of the first 100 showed that they were unlikely to meet their primary endpoint of improving death. Importantly, there were no safety concerns. The full data set is really still being looked at and the publication is pending. I do sit on the steering committee. I can only say that there are clinically relevant findings that are noted in some of the secondary endpoints, but without giving more information. Actually, I don't have much more information than that as we look at the data. What was most interesting is that in the midst of BREATHE, dexamethasone, based on the recovery study, became the standard of care for COVID worldwide. And so initially the thought was to study Gimsulimab versus placebo as the only anti-inflammatory, but then in the middle of it, everyone started being put on steroids. And so I think that will be an issue that I'll talk about a little bit later about how complex these trials are, how fast things are moving in the COVID era. The second trial that followed was Mavri. Mavri was the first company to contact us, but they actually were a little slower to start their phase 2, phase 3. They're now actively enrolling up to 570 patients. They're doing a phase 2 first and then a phase 3, but in total, they hope to enroll this many patients in a 1-to-1-to-1 ratio of a high dose Mavri versus low dose Mavri versus placebo. We have enrolled 11 patients thus far. And this is targeting any hypoxic inflammatory COVID-19 pneumonia patient. So any amount of oxygen here with the right poor prognostic markers all the way to mechanical ventilation, again, without severe multi-organ failure. So allowed to have some kidney injury, but not allowed to be on dialysis. The primary outcome for cohort 1, which is the non-ventilated cohort, is the proportion of patients alive and without respiratory failure on day 15. And the primary outcome for the cohort 2, which is the ventilated cohort, is mortality. Enrollment is about 20% complete at this point. Though with the surge, it's actually probably going to increase quite a bit. So when we take a step back, what have we learned thus far about targets? And I'll just say that, interestingly enough, I mean, it's 2020 and there has never been an FDA-approved medication for sepsis or ARDS. And I think that's the difficulty of these targets, is that it's heterogeneous, they're up and they're down. We don't know which target is the right target. And I think the one medication that was FDA approved for sepsis many years ago was actually taken off the market subsequently. But what we know so far, not surprisingly, IL-6 receptor blockade is actually not the answer. Many of us felt this way at the very beginning. We did have the Tocilizumab and the Mavrililumab trial, so we contributed to both of these trials. But again, I think I showed you data that the IL-6 levels are not even that high in COVID. And many of us on the ground have concerns about IL-6 blockade being immunosuppressive, especially with steroids, and have certainly seen a number of opportunistic infections. Baricitinib, a JAK2 inhibitor, which was studied in ACT2, which is a large NIH trial. This publication, I think, is coming out very soon. Actually just got an EUA as of yesterday, I believe, based on some promising results on recovery time, decreasing recovery time, improving the ordinal scale that I showed you, as well as mortality in the sicker hypoxic patients. This was not a trial that was powered for mortality, but it did show a mortality benefit, especially in the cohort that had a baseline ordinal scale of 5 and 6. So that is a group that's on high flow oxygen or the group that's on mechanical ventilation. So again, these patients are actually quite sick. The jury is still out for the rest. Steroids, which of course is a non-specific anti-inflammatory agent, has been most convincing for mortality improvement in severe COVID. And again, that kind of fits with our general skepticism that we've always had about very, very specific targets versus more non-specific targets. The recovery study, for those of you who haven't heard about it, I'm sure everyone has at this point, but did show a reduction in 28-day mortality in those that are oxygen dependent or ventilator dependent, using a moderate dose of 6 milligrams daily of dexamethasone for up to 10 days. So that again became standard of care in the midst of the pandemic. So some days when I think about this, I think maybe we have more questions than even answers. Again, I've been saying this from the beginning. In ARDS and sepsis, the key is likely timing, dose, and duration. So for example, steroids in late ARDS we know actually causes harm. So we want to quell the inflammation at the right time with the right dose, but not in a way that leads to immunosuppression or secondary infections. And many times people with septic shock actually don't die of the initial infection, they die of a secondary infection weeks later. It is sort of the thought of many that once you're on the ventilator, it may be too late for many. Certainly if you're on the ventilator for more than a day or two, potentially these patients actually may be too late to interrupt this inflammatory cascade. And then of course, because things happen so quickly in COVID, is that the anti-inflammatory agents were meant to be studied alone. They were meant to be studied versus placebo, but the standard of care has quickly become steroids. So are these medications better than steroids? What are the effect of these medications versus steroids? So ACT4, which is going to be baricitinib versus dexamethasone, hopefully will help answer this. What is the effect of these drugs with steroids, right? So we always get a bit paranoid that these patients are going to develop secondary infections. There's been some early reports of invasive fungal infections. We've seen it here with aspergillus and COVID. Even without steroids, what are we going to do when we give steroids plus another anti-inflammatory agent? And again, I think GM-CSF blockade, is it really immunosuppressive is a big question. I think it does have the risk of being immunosuppressive. The patients with PAP are, again, they have a real, though it's a relatively mild immunosuppression. So I don't think we know the answer to these questions. So I want to spend the last few minutes just talking about, again, my hat as a clinical, sort of physician on the ground, an ICU doc. And so how do we save COVID patients and how have we saved COVID patients at UCLA? And the focus of our group from the very, very beginning has just been to stick with what you know, right? Do high quality supportive quick care. We know how to manage ARDS and shock and renal failure and delirium. And as much as we didn't know about COVID, we knew how to manage, we knew how to provide supportive care. And the challenge here has been to manage these patients with the standard of care for all the critical care illness that we know how to treat. Obviously, while avoiding infection of healthcare workers, for example, running in during a cardiac arrest without PPE, but avoiding, sort of infecting our workforce was a huge priority of mine as the clinical chief and the fellowship program director. But also like not reacting to the dynamic rapid reporting. If any of you guys are on Twitter, right? Every single day there's something on Twitter that is claiming that it saved a patient life. And things that were being published were anecdotes, and even things that were being published in New England Journal of Medicine were largely case series. And so we've been able to at least at UCLA, to stick with our supportive care and to offer therapeutics all via clinical trials. And so every UCLA patient is offered a clinical trial. Now, in my pre-COVID life, most of my clinical trial experience was in the outpatient setting, and I have a newfound respect for those that do it in the inpatient setting because it's actually been very, very complex. Specifically during COVID, the sheer number of companies trying to repurpose medicines to treat COVID had to lead to a COVID clinical trials prioritization committee that I sat on with a variety of ID and pulmonary physicians, including Steve Duminit, Judy Courier, Arash Naeem, Steve Chang, to basically figure out what trials we want to bring at UCLA. I probably still get 2 emails a week asking to join us a new COVID clinical trial. UCLA has been busy with COVID, but we've not been New York busy or Italy busy. And so the sheer number of trials that we accepted, both NIH and pharma, led to this need for air traffic control on the ground to basically decide which patient goes into which trial, which is not an easy conversation sometimes. I think I mentioned this already, but remaining free from bias was actually quite hard, I think, in this era for both the clinicians and the researchers. And I think that it's hard to ignore the human factor when you're treating a devastating disease affecting young, largely underrepresented minorities that presents in masses. And so there's this desperation where you want to give something, and you start believing that giving something is better than not giving anything. And so again, that's actually been the challenge on the ground. I think the rapid FDA EUAs have made things even more complicated. So now that baricitinib is approved under an EUA, and now that steroids are standard of care, are people going to sign up for Act 4, which is baricitinib versus steroids? So I think it's actually been complicated, for example, to do convalescent plasma trials when the EUA came out. But at the end of the day, I am extremely proud to have been part of this effort and have an immense amount of respect for all the clinicians and researchers who have really been focused on COVID care. Some other keys to success in our ICU, I think we obviously had to strategically staff our units. We had cohorting plans. We still have a COVID kind of a cohorted unit in our MICU for geographic care. It does conserve PPE and helps focus the staff. Again, sticking with what we know and enrolling everyone to a clinical trial. And simply a belief in your PPE and the willingness to provide this high quality, but really, really cumbersome critical care. And that's not just the MDs, that's the nurses, the respiratory therapists, the environmental services, the lift team, honestly, in the hospital. And one of the reasons I love crit care and always have and always will is that it's always been a team sport. You know, COVID is a team-based marathon. This is a longer marathon than any of us wanted to run, but it is all about the team and celebrating the successes of that team. And so I do want to focus on that, as you know, the truth is that doing a COVID ICU week it can be quite demoralizing and lead to burnout. Sorry, the light in my office just went out because I stopped moving. But I do want to focus on at least some of our statistics and acknowledge the team that's been taking care of these patients from day one. So a couple of pictures. So, one of the things that we do is we actually prone these patients. And you can see how many people it takes sometimes to prone these patients. Some of these patients have a very elevated BMI. You have someone holding the ET tube to make sure none of the catheters and the tubes come out. You have physicians in the room oftentimes looking at the monitor to make sure the patients are hemodynamically stable. So this is a gargantuan effort, and this is being done every single day to the majority of the COVID patients that are sick and on mechanical ventilation. So it takes a lot of again, cumbersome care on the ground. This is actually, I really like this picture. This is actually one of the first patients that was intubated for COVID at UCLA. This is actually one of my trainees, and I always am so impressed by my trainees who, what a weird time to train in pulmonary critical care and learn how to do these procedures and learn how to take care of these patients during a pandemic. But, they had a moment to basically shoot this picture to sort of improve morale. And then nurses had to do really creative things like take all the IV pumps out of the room, so we didn't have to go into the room to adjust medications and to give you an idea of how sick these COVID patients are. It might be one patient that needs all these IV pumps just to keep them alive. This is the first intubation. This is actually me back here that I did on a COVID patient, actually when our trainees were in clinic. This is Steve Chang. And so again, we normally would not have this many people in the room to intubate someone. And obviously everyone is in PPE, but it's all about having protocols and having safety protocols and having backup. And everyone has been very, very willing to help out in this really sick patient population. And then this is actually caught on camera. This is one of our nurses, Roman, doing CPR actually on our first COVID death. This is back in March. And someone actually caught this on film. This gentleman actually came into the hospital at the age of 29 and died at the age of 30 from COVID, and it was actually our first COVID death. And so again, a lot of people have been lost in this pandemic. But I want to end again on a hopeful note and pull some stats, because sometimes I think that the way we feel in the ICU does not reflect the overall stats. Looking quickly at my own GM-CSF trials, which I look at every single day, we've enrolled 38 patients. 4 of them are still in-house and have been enrolled in the last couple of weeks, but there's only been 1 death so far, and 33 patients have survived a discharge. And this is not at all me saying that this medication works. This is me saying that for a group that's actually sick and has poor prognostic markers, they're doing very well. Obviously, many of these patients are getting placebo. But the UCLA stats for inpatient COVID have actually been quite impressive. This is the number of total hospital admissions as of about 3 or 4 days ago. When I looked at the dashboard, we've had 260 ICU admissions. These admissions are going up every single day. But our overall inpatient mortality has been actually very, very low. It's been less than 10%. It's currently at 7.5%. And even the ICU mortality is less than 20% if you look at the entire cohort. And one thing I do have to acknowledge is that we never, again, got to New York numbers and got to Italy numbers. So we were never in a situation where we didn't have an ICU doc or the right staff taking care of the patient. So we definitely became very, very busy and had extra ICU docs, but we always did what we were good at doing. And this also takes into consideration, though, that we took and continue to take a large number of extremely critically ill patients and transfer from outside hospitals. Just this past week, we took a 32-year-old that couldn't ventilate at an outside hospital. And we took a pregnant a patient from an outside hospital as well. And so we are taking very high-risk patients, and yet our metrics actually look quite good. Many people have been saying that this is because we have gotten very good at taking care of COVID, but I actually wanted to show some stats from the very beginning of the pandemic, and we actually have had this paper, I believe, accepted at PLOS. It just needs a small revision. But of our first 112 patients admitted to UCLA between March and April, almost half of them were admitted to the ICU. But the in-hospital mortality here was actually, again, quite low at 6%. Our ICU mortality was 13%. Even our ICU ventilated mortality was 18%. And we looked at what we call evidence-based ventilator adherence, so ventilating everyone the correct way with low tide volume ventilation, it was actually above 90%. And there was a very high rate of proning. So prior proning studies for ARDS would show that maybe 10% of patients that were eligible to be prone were proned, and our numbers were closer to 60%. There is going to be a cohort that you can't prone for whatever reason, for example, pregnancy. But I think the argument here is that we've been able to provide, sort of standard of care for these ICU illnesses. In this really, really small cohort that we are publishing, obesity, smoking status, and elevated inflammatory markers were the risk factors for mechanical ventilation. I just really quickly wanted to acknowledge the team. So we've been, dealing with this since March. There's a pandemic disaster response team that I have been running with Dr. Kadir, but there's been leads in all of these areas with clinical guidelines, and Katie Melamed and Steve Chang helping with the research aspect of it. Everyone's been involved in the surge planning. Where do we put the ICU patients when we run out of ICU beds? Who's going to take care of those patients? Crisis standards of care, for example. What if we get to the point where we have to limit certain interventions? We have to make hard decisions about who cannot get ICU care. So we involved the ethicists in this, of course. We also, it's not just about taking care of the patients in the ICU. These patients, these ICU survivors have a lot of issues. They have issues with pulmonary function. They have issues with PTSD. They have issues with neuromuscular weakness. And so Christian Schwabman, our junior faculty, has started a post-ICU clinic for all the post-COVID care, which is going to be another area that is ripe for research. And of course, all the amazing frontline faculty and fellows who've been doing this we've been doing this for more than 8 months. And I've never been proud of our faculty. So some suggested readings. Again, this is largely around the GM-CSF pathway. This third paper is actually one that Eleanor and I co-authored. And then ending on the note that the most interesting thing that I actually wrote during COVID was not an academic paper, was actually an editorial by myself and 2 amazing women physicians here, Nita Kadir in my division and Tara Vijayan in the ID division, that we needed to really take a step back and acknowledge how hard it was to make clinical decisions in the era of COVID, and that we completely stopped talking about this meticulous supportive care. We just wanted to find this magic bullet to cure COVID. Whether or not we find the magic bullet, I certainly hope that we do. The emphasis has to be on doing things that we know and doing things that are evidence-based, which has actually been, like I said, very, very hard during a global pandemic. That's all I have. I'm happy to answer hopefully clinical questions, but I'll do the best I can with any questions that you guys may have. Thanks for the invitation, Melody and Bridget, and thanks for everyone's attention.
Great, thank you so much, Tisha. That was amazing, and thank you and to your team for the hard work you put in. It's really amazing to see the human story side of it. So I guess we'll open the floor up for questions. And if you want to unmute yourself or, type in your question in the chat, I can mediate that. I guess I'll start with my question is that I think I thought it was really interesting that you brought up that the timing is everything. It's such a tricky situation where if you want to give the patients immunosuppressive drugs, that if you do it too early, it's probably not good for fighting the infection. But if you do it too late, then you kind of miss the window. I guess what I'm curious about is, do you think there's markers or, you talked about IL-6 level. Are there any molecular markers that you can monitor in the patient every day or regularly that could give you more sort of insights or information into when will be the perfect timing for each individual patient, which I think is quite a challenging task, right?
I think what you are saying is the dream that the ICU docs have had for decades, right? Of having like a test that you can check every single day. I mean, we have tests that we check every single day, like the CRP, like the D-dimer, like the LDH. It gives you an idea, and you see these fluctuate all the time. Actually, you see someone getting an agent and the CRP goes up, and then for whatever reason it goes back up a little bit later. But those are not clean markers in any way. And if you look at some of the previous trials that failed in blocking individual markers, they did do a point of care everyday test, right? Interleukin blank, 1, 6, whatever it may be. And they would base it on that, but those never improved outcomes. It's probably because it's not about the interleukin 1, interleukin 6, it's about the global inflammatory state, right, of that individual patient. And I don't think we have a good marker for that. As of now, I think that I saw Bernie Kubak on this call earlier. I mean, there's this concept of like having a test to see what your immune system is doing at any given time. But it's not so clear to us actually. And these patients, if you were to do this in a research setting, actually very early in my fellowship, I wrote a paper about sort of the inflammatory syndrome, SIRS, right? And then, but you also have this anti-inflammatory syndrome that occurs afterwards, right? That's sort of CARS. But then you have MARS, which is like a mixed anti-inflammatory syndrome. So at any given time, I don't know that we know where that patient is. There are surrogates like fever, like, CRP, but I don't think there's a very clean marker. But I think if there was, that would be the way to treat each individual patient completely differently, as opposed to just saying we're using steroids for ARDS or steroids for something. So. I'm not sure if that's a good answer. I guess I just don't know.
Thank you.
It's a good answer. Quickly, Bernie Kubak. Tisha, that was excellent as usual. I bought stock in you years ago, and I'll stay with it now. I'm going to reinforce your comment about the earlier sepsis trials and ARDS, having run 3 of them here at Abraham and Gil Cryer. Unfortunately, they weren't as optimistic. We could never prevent that ARDS or the pulmonary fibrosis that ended. And even with Zygris, we couldn't do that. So my question to you is, yesterday I dissected literally all the lungs with Northwestern, who've done 9 lung transplants for COVID-19 disease. And they published a paper, it's a preprint now, and having worked with Northwestern years ago, the pulmonary fibrosis is dramatic. And it does resemble the end-stage pulmonary fibrosis we do see. Do you anticipate perhaps the GM-CSF modifiers or blockers, take your pick, to impact that stage? Is that the goal of the GM-CSF approach that you're taking?
Yeah, I mean, again, in the very simple mind of a clinician, what we think about in ARDS is inflammation either goes away, right, or inflammation eventually becomes fibroproliferative. And when that happens, I think is different for each individual patient. And this is completely anecdotal, but I feel like sometimes in COVID, it occurs maybe even a little bit later than what we used to say in ARDS, which is like, if you don't get better by 7 to 10 days, you're probably going into a fibroproliferative phase. But yeah, absolutely. I think that the concept is that if you quell the inflammation and it's going away, it's not gonna be this nidus for fibrosis, and hitting it at the right time, without, again, causing so much immunosuppression that you're going to get secondary pneumonia later. That's that's in my mind the key. It's not a simple answer, but yeah, we're trying to prevent death, but absolutely we're trying to prevent, right, needing a lung transplant later. I mean, or needing, having severe pulmonary dysfunction moving forward. So
yeah, no, yeah, I think you're on the right track there, at least investigatively. So thank you so much. That was great today.
yeah, thanks, Bernie.
Great. So our next question is from Yanka Bulut. Excellent talk. What do you think about WHO announcing remdesivir to be not useful in COVID yesterday? Same day FDA issued authorization for combination of baricitinib and remdesivir.
So that's a great question, actually. This question actually came up this morning in a Department of Medicine meeting. And so I'm going to steal Judy Courier's answer, who's much smarter than I am. But I think that there are some considerations when the WHO make announcements that when they're recommending a drug, that many parts of the world have no access to this drug. And so they get put in a situation where they're recommending remdesivir for everybody, and then they're getting bombarded by countries that don't have remdesivir. You're recommending this drug, we can't give it. And so that there probably is that component there, as opposed to the FDA and the US, which actually has a supply. I think if you look at the remdesivir New England Journal of Medicine paper, my interpretation was that it does improve the number of days that you're sick, right? So it improves clinical recovery. I think the question about mortality is a different question because there was a suggestion in that New England Journal of Medicine paper, but the numbers were so small that I don't think you can make a real conclusion. So I think that our approach is to consider giving to continue giving the antiviral, especially if you can get the patients early. I think there's some debate whether or not to give the antiviral late for someone who's, say, 3 weeks into the presentation, because do they really even have a viral load anymore? Some of them don't even test positive anymore. That in that situation, you're fighting the inflammation. But I think that people are going to continue to use it in the US. And I think there, again, was some consideration about that recommendation because of supply, not just because of what they thought was maybe appropriate. Again, just based on what Judy Courier mentioned this morning and her insight into the WHO.
Thank you. No, that makes a lot of sense.
Thank you, Tisha. Thank you.
Yeah, you're welcome.
I guess there's no more other questions. Maybe I'll ask one more question, Tisha, if you don't mind. You mentioned JAK2 inhibitor. I'm curious if anybody is looking at interferon receptor inhibitor or interferon inhibitor, because this study from Rockefeller, from Jean-Laurent Casanova's lab, they found that there are actually these auto antibodies to interferon. What do you think about that?
So ACT3 was actually interferon. ACT3 was remdesivir versus interferon. And so that just finished enrolling. So we should have an answer on that. The only comment I'll make is that very early in this, they actually noticed a safety signal in this very sick patients. So in the ICU patients that are on a lot of oxygen or on the ventilator, they were eligible for ACT3 at the very beginning. And then they did like a interim analysis and they basically stopped enrolling those patients because they perhaps saw a signal there that maybe they were making them worse. But interferon absolutely has been considered. And I think that clinical trial data will be published in the near future.
Great, cool. Well, thank you so much.
Yeah. Yeah. Thanks so much for everybody for coming. I appreciate it.
Yeah, thanks. And I think next week, I guess, is Thanksgiving. So we'll see everybody in 2 weeks. But thank you so much, Tisha, for a very stimulating talk. So yeah. Have
Thanks.
a good weekend, everybody.
Yeah.
Bye. Thank
Bye.
you. Bye.